It is October 24th, 2025. This is Tales from the Heart, a podcast from the Hypertrophic Cardiomyopathy Association. And I am Lisa Salberg, your host, and I am joined today by Dr. Steve Ommen from the Mayo Clinic. Good morning, Steve.
Good morning, Lisa.
How have you been since last we've chatted?
I've been good. We had our first hard freeze last night, so winter is upon us here in Minnesota, and I'm just back from 3 weeks of completely off work, so I'm kind of shaking out the cobwebs.
Yeah, we got to get you back in action because we don't want you getting too used to that life of luxury of not having to work every day. God forbid we give you some time to rest and relax. So we are here. I'm in Jersey. It's full on fall. The colors actually are gorgeous this year.
Yeah.
Some of the reds came back. I was happy to see that. We lost a lot of ash trees. So we lost a lot of our reds. So they're back. And we are back in the office, refreshed after a very busy weekend last weekend. We missed you in Morristown. Hope to get you back out here next year. We had the HCMA annual meeting, CME course, gala, and 5K all in a weekend.
Wow.
To say my team deserves to rest this weekend is putting it lightly. We all did an amazing job getting everything ready for everybody to show up, and we had an enthusiastic crowd of big-hearted folks who were craving information, and we delivered, and we made some lifelong bonds this weekend. Our board solidified our strategic plan this weekend, and so you're going to see some new concepts coming out of HCMA and new packaging of projects and maybe some new titles floating around sometime soon as well. Hint, hint, nudge, nudge. So a lot coming up here at HCMA, and we're just really excited about what's going on in the world of HCM. Lots of new opportunities for research, trials opening for patients, some new centers coming onto the scene, lots of stuff going on, and we're excited to roll out 2026 and put 2025 in the rearview mirror. Steve, a lot's happened since the fall started, and there's been some interesting information circulating about some trials that have been read out. So you want to give us your hot topics for the month of October 2025?
Yeah, I think probably the biggest discussion that you hear is around the Maple HCM trial, which was a study of a new cardiac myosin inhibitor directly compared to the use of metoprolol as single agents, and it was positive for the CMI, and I think that's interesting. We can talk about this some more, but I think it's even more interesting because some of the spin and jumps to conclusions that is gaining traction on social media and other places about what this means for patients with hypertrophic cardiomyopathy. That perhaps there's some hyperbole playing out there, despite the fact that, again, it's a very positive study for, again, this new class of agents that we're using.
So there was some information that I think bears repeating and clarification because it's a little confusing to some. So beta blocker versus calcium channel blocker. The data showed the calcium channel blocker, or I'm sorry, it's myosin inhibitor. I can talk real good.
Yeah.
Wow.
Yeah.
It's been a long week. It's been a very long week. Let me redo that whole thing.
Yeah.
So when you looked at a myosin inhibitor versus a beta blocker, the myosin inhibitor responded much better to dealing with obstruction in HCM. So patients were hearing right up front, beta blocker not working as well, go to a myosin inhibitor first. But we're talking specifically about obstruction. Can you speak to the role of a beta blocker in obstruction and a role of a beta blocker in HCM outside of obstruction?
Yeah, good question. So beta blockers, again, are medications that block some of the effects of adrenaline on your heart, which means it can slow the heart rate down, it can decrease blood pressure, it can decrease how hard the heart contracts, amongst the main features. For patients with obstructive hypertrophic cardiomyopathy, the decrease in the force of contraction can decrease how much the obstruction gets worse when a patient becomes active. the fact that it slows the heart rate down gives the heart more time to fill between heartbeats, which also decreases obstruction. So that's the theory and the practice and the proof that Braunwald and team did years ago around beta blockers and the effect on obstructive physiology. As many of your patients can attest, there are some side effects with beta blockers that are also related to block of adrenaline, meaning they don't feel as motivated, even some mild depression in people. It can cause some fatigue in people and a host of other side effects that some people don't like for beta blockers. And their effect goes so far, but we do know that many patients have benefited from and continue to benefit from therapy with beta blockers.
So in those patients who might be using beta blockers to keep their heart rate down because they have a lot of tachycardia or they have some other issues that they're trying to reduce their heart rate, is there still a role for a beta blocker in that patient population?
Absolutely. I mean, obviously, to your point, if they're having supraventricular tachycardia, AFib, any of those kind of things, and you want the heart rate to be controlled a bit, the beta blocker is a really good choice for that. For patients both with and without obstruction, one of the things that causes patients to have symptoms is oxygen debt within the heart muscle that we call ischemia. And ischemia is basically a supply-demand mismatch of oxygen. The amount of oxygen that can be delivered to your heart is dependent on blood flow, and we're not talking about blockages in arteries, but because there's more muscle that's demanding to be fed, there's more myocardial oxygen demand. Beta blockers, when it decreases the heart rate and decreases the force of contraction, reduce the amount of oxygen the heart's asking for, and so can keep people out of that ischemia, which can cause chest tightness, chest pain, or some patients can describe that as shortness of breath as well. So over and above the obstruction to flow leaving the heart, which beta blockers can address, they also can address the subendocardial, deep within the heart muscle, ischemia, oxygen debt that can cause symptoms.
So beta blockers aren't going anywhere out of the playbook at this time?
They should not.
We would agree. Okay. So it is Sudden Cardiac Arrest Awareness Month.
Okay. Before we leave that topic,
go back.
I think it's worth, again, because of some of the narrative that's come up where people are now suggesting that maybe a cardiac myosin inhibitor should be the first drug that people are put on when they have hypertrophic cardiomyopathy. I think that deserves a little bit of discussion because that's a
whole podcast in itself, but let's spend some time on it today.
Yeah, that's not what that study showed, just to be perfectly clear. So first of all, the drug tested, aficamten, is not yet clinically approved for use. We all think it's going to be, but it's a federal government agency and things slow down and there's closed doors and those kind of things. So it's not yet approved, so it's not available. But what that study showed, in order to be eligible to be in the trial, patients had to be symptomatic,
yep,
most of whom were on beta blockers and symptomatic.
Yep.
And then they would go off of their beta blockers and get randomized to beta blocker or aficamten. But if you think about that, that means the patients who were on beta blockers that were no longer having symptoms were never part of the study. The only patients part of the study were patients who were already failing beta blockers. And then the trial was comparing, are you better to continue to fail a beta blocker or be on the new drug aficamten? And so the study's clear, you're better off being on aficamten than continuing a drug that you're failing already. That's in the details of the methodology, and it's really important that we look at the way studies are designed, that you understand those kind of entry criteria. What is important is that our current clinical practice is, for the clinically approved cardiac myosin inhibitor mavacamten, patients are eligible for it if they're not successfully treated with beta blockers or calcium channel blockers, and you add mavacamten to it. And this was the first trial that said, should we replace the drug rather than adding a drug? So the really important thing is patients may only need to take one drug if they're failing beta blockers and not two drugs, which, as you know, for many people, that's a win, because we have a tendency just to accumulate the number of drugs you take per day. And here, this study actually showed it's better to switch than to continue, than wholly to aficamten, assuming that gets approved. So I think it's an important study. It shows that single drug therapy with aficamten in this case was superior than continuing to go higher on your dose of beta blockers that you were already failing. It's an important study, but it does not say the first drug out of the box should be a cardiac myosin inhibitor, because the patients who were successfully treated with their other therapies weren't eligible to be in the trial.
That is going to be an evolving debate. I think AHA is going to be interesting coming up in a couple of weeks, where we start having these conversations on stage. And I think when we take the time to break down who's doing best on which therapy, yet again, HCM remains very individualized in its treatment approach. Yep. So not everybody's obstruction needs exactly the same thing. Yep. And again, I wish that in some ways that it would get easier and we didn't need to rely upon multidisciplinary care programs for HCM. Yep. But having everybody have a voice here remains to be critically important.
And I do think that there are many patients who their cardiac symptoms have gotten better on their beta blockers, who kind of have said, well, I'll just suck it up and suffer through some of these side effects. And now that there's other options, there'll be more that switch over than we would have been eligible before. But again, we shouldn't throw out the baby with the bathwater. These old school drugs with the right physiology behind them are effective for many patients. They're inexpensive and they don't require complex follow-up.
So beta blockers aren't dead. They are still a part of the tool chest, and they are really important, especially in parts of the country or parts of the world where you can't get access to newer stuff.
Right.
And it's gonna stay that way for a long time. But lots of exciting news coming. I hope we have some good news to report before the year's end or early in the new year. With government shutdowns, God only knows what's going to happen. So let's hope that everybody gets back to work soon. I'll just leave it on that because we don't want to go down that rabbit hole too deeply. But it would be nice to have things working normally. So we do have a question before we get on to Sudden Cardiac Arrest Awareness Month. And that is a question about Camzyos. Does it help control atrial fibrillation? Ooh, tough question.
Super tough question. And I think the most honest answer is probably not. In fact, we have data that we have published that would suggest that Camzyos, mavacamten, promotes atrial fibrillation. Among patients who have never had atrial fibrillation before, 15% of them get their first ever episode of atrial fibrillation within 6 months of starting mavacamten. And among patients who had AFib that had been controlled, 75% of them get a recurrence within the first 6 weeks of starting mavacamten. And we don't know the method for that, although the supposition is that cardiac myosin doesn't just exist in the ventricular cells, it exists in the atrial cells as well. And so somehow the cardiac myosin inhibitor might be making those cells less efficient themselves, which may secondarily make them more vulnerable to atrial fibrillation.
Because they go into AFib when they're starting the drug, does that mean that they're going to stay in AFib? Are these paroxysmal? Are they persistent? Do we have enough data?
We don't have enough data, but I think it's clear just amongst the patients that I've seen, it varies. Like you just said before, it's person by person. There's one patient I had that had super easy to control AFib before, and when she started taking this drug, couldn't even cardiovert her out of her atrial fibrillation for a while. Other patients have been paroxysmal. The other confounding thing, though, is some of the patients, when they go into atrial fibrillation, the heart rate goes too fast and the ejection fraction falls, which then means we have to stop their mavacamten per protocol, per FDA mandate because of the drop in ejection fraction. So it gets to be a complicated thing in those first few months after starting the drug monitoring for that.
The exciting thing about having new therapies available is many people benefit.
Yeah.
The annoying part of having a new therapy is you find out where the cracks are as you get it out into the population more so. And there were some very, very early signs that AFib might be affected.
Mm-hmm.
And we saw this in the first couple of weeks of the label, but we didn't understand who and why and how.
Yep.
And I don't think there was a way to find the who and the what and the how until we got it out in the world and saw real world utilization. I don't see this as a failure on the discovery team or the launch team. We're learning together. And that's part of this adventure with a regulatory body, with a pharma company, with clinicians, with patients. When it's new, things shake out. And it takes a little while to figure it all out. And we're figuring it out.
Mm-hmm.
And we're developing approaches and figuring out who might be at a higher risk of having AFib or having a recurrence of AFib. So again, really important that you work with a multidisciplinary care team to help prepare and understand what your expectations can and should be on any particular therapy. I think I've descended from my soapbox now. What about you?
Yeah. We can now talk about the topic you wanted to talk about. Sorry for hijacking.
Well, no, it's a good topic. Like we could do a podcast for a day and a half on the advent of myosin inhibition and HCM. But it is Sudden Cardiac Arrest Awareness Month. And for some, that invokes memories of very traumatic events that you or a loved one faced. And for others, it's the cautionary tale, which we hope to avoid at all cost. And for a clinician, it's how do I figure out who's at risk, much like we're talking about AFib in the space of myosin inhibitors and who might be at risk for that. Sudden cardiac arrest doesn't go away in HCM. The risk doesn't ever go to zero for anybody. For any human, it doesn't go to zero.
Yep.
But how do we identify those who are at highest risk for sudden cardiac arrest and who warrant a defibrillator? And then we have some new options on defibrillators we can chat about.
Yeah.
So what have we learned about sudden cardiac arrest in HCM in 10 minutes or less?
Oh, goodness. 10 minutes or less.
We have 40 whole minutes to talk, but I'm sure some people are going to have some questions.
Yeah. So, it's an interesting history. So the first kind of paper that's recognized in the modern era, 1956 being modern, 58, was an autopsy series of 8 patients all under the age of 45. So at the first description of hypertrophic cardiomyopathy, not called that at that time, was a sudden cardiac death series. Over the years, we have learned that it's not near that common that sudden death occurs. It occurs in just less than 1% of patients with HCM, which is a low number, but it's not low enough to ignore, obviously, because, families are affected by this. So there have been a number of approaches over the years that have continued to evolve for trying to identify patients at higher risk for cardiac arrest. And beginning in the 1980s, with the advent of the implantable cardioverter defibrillator, who might be eligible for one of those devices to go in. And so the 80s is when the interest in identifying, and therefore because we had now a preventative therapy, might be helpful. I think it's worth a sidebar here to say no drug therapy has ever been proven successful at preventing sudden cardiac death, including some of the antiarrhythmic drugs that are good in other cardiac conditions, just don't seem to work in HCM for preventing SCD. So really, the only therapy we have for those who are at risk is the defibrillator.
So because I'm a history geek,
yeah.
and I want people to understand that humans make things happen, not the ether, I have to give props to Michelle Moravsky.
Yep.
And his very first paper. If you do not know this man's story, please go look at it now. I'm going to drop a link myself as we do this. His history, his legacy is absolutely breathtaking. And you're like, wow, just who he was as a person, what he did to bring his science to people. He's just an incredible human. And the first handful of patients that he successfully used an implantable defibrillator on, it appears that 3 out of the 4 were probably HCM patients, but not discussed as such. And that was in the early 1980s. And it would take us until the late 1990s to get a labeled indication for an ICD and HCM, even though we were the first ones he actually looked at. So I'm going to drop a link here from Hopkins on an article about him if anybody's interested in reading it. So props to him, and then props to Barry Marin for taking the knowledge of the technology and really trying to plug it into HCM, and he helped us get that labeled indication. So it took a lot of people to create the technology. And then Wilson Greatbatch, who developed the battery that goes inside the defibrillator. People, I need a hobby outside of cardiology history because I could go down some geeky rabbit holes. But some of these visionaries who thought about technology back in the 70s and 80s, and now we're going into, well beyond that, just give them props. To work with the technology that they had at the time to create what they created is amazing. Yeah. Now back to HCM. So we have risk factors that we've identified.
Yeah. So just for the audience sake, so, now that we've got this device that maybe we can prevent sudden death, should we put it in everyone? Well, that ends up being the wrong decision that, everyone will clearly see, because most people don't ever have cardiac arrest. The devices were big, complicated implantations back in the day. So how do we identify the patients who are most likely to benefit, AKA the higher risk patients? And people like Dr. Marin, my predecessors at Mayo Clinic, all the UK team, the Toronto team, all started looking at their databases, and you might identify, gosh, it seems like sudden death also runs in certain families. So then a family history for sudden cardiac death became one of the risk factors we look at. Paulo Spirito did the study that looked at the thicker the heart, the higher the risk. And so then we got to this concept of massive hypertrophy as a risk factor. And after we had a number of these risk factors, kind of in the 2000s, for the first 10 years of the 2000s, we were in a state where basically you looked at, does a patient have 0, 1, or more than 1 risk factors for cardiac arrest? And then there was a discussion with the patient. And almost universally, if they had 2 or more risk factors for cardiac arrest, it was recommended that they consider getting a defibrillator. If they had 0 risk factors, they were kind of reassured, with the caveat, as you said, there's no such thing as a 0 risk person. And there was kind of an international debate about what to do with the people with 1 risk factor, with some saying 1 risk factor is enough, and some saying it's not enough. And it all depends on, are you going to put in more defibrillators that don't do anything? Are you going to put in less defibrillators but miss some patients who might die, et cetera? And it was a tough, vigorous academic debate for those years. And we sought to bring some thoughtfulness to this with the 2011 HCM guidelines, co-chaired by Drs. Gersh and Marin. And we went back and looked at the data for all of the risk factors and tried to look at those that had the most robust data. Which ones had data that, massive hypertrophy was important, and it remained important even when you accounted for other risk factors. So it wasn't kind of an epiphenomenon. And so we tried to rank the risk factors or put them in groups. And there was a handful: massive hypertrophy, family history of cardiac arrest, or arrhythmogenic fainting, syncope. Felt like if you had one of those, that was sufficient to warrant an ICD. There was a couple of other ones that by themselves maybe weren't enough, but maybe in combination with other near risk factors or risk modifiers could be enough. And so we kind of evolved to that methodology, and it was based on science, based on evidence. And that, I think, evolved the process from simply risk factor counting to trying to figure out which ones were most important. Then our colleagues in Europe pooled a bunch of data and came up with the HCM, sudden cardiac death risk calculation, which looks at all of those risk factors and through well-founded but complicated math can give a patient
very complicated math,
an estimate of what their risk for dying suddenly in the next 5 years will be. And I don't know how much you want me to go into the nuances between those two methodologies, but there was some debate about which one was best. To cut to the end, what we've done in the last two versions of the ACC/AHA guidelines is combine the two methodologies, use them both. Because if we just simply look at, you have these important risk factors, therefore you are eligible for an ICD, that's great. And that helps some people understand, some patients understand, yes, I have risk. And then we can use the calculator to give them an estimate of, when you say I'm high risk, what does that mean? And you can say your risk is...
Let's stick there for a second.
Yeah.
This has always been my bone of contention.
Yeah.
So when Perry Elliott, who was one of the leads on creating the ESC risk score, he brought it to me at AHA many years ago before it was public. And he's like, what do you think? I'm like, very helpful to have something written down, but who decided that 4% was okay? Who decided that 4% risk is low?
Oh, yeah.
And I've always been stuck on that.
Yeah. So you're getting right to the point I wanted to make. So the idea of having a numeric percent is very helpful. To pre-label different percentages as high or low risk actually biases the interpretation of the patient. There's well-founded research going back to the 1970s and probably before that. If we pre-label categories of risk percentage, people make more emotional decisions rather than logical decisions, if you have that information. So I think it's important that people have the risk number. You say, I have risk factors. How high is my risk? You said my risk is 6%. Some people will say, that sounds like a 94% chance nothing's going to happen to me in 5 years. I'm pretty happy with that. I don't need a device. And that's part of the shared decision-making process, is learning where the patient's risk tolerances are and how much risk they're willing to tolerate, coupled with the risk of putting in a device, et cetera. But I think pre-labeling risk percentages or just slotting people into categories results in a tendency towards emotion-laden decisions rather than logic-related decies.
But this is a tough one for logic. I have to admit that logic sometimes is not balanced here.
Yep. Well, and in the end, every time any of us makes any decision, I mean, it's not obviously this can be a life or death decision, but any decision we make, ultimately it is a gut call. I mean, even the most logical of us, if you're thinking about whether I should get that new car, in the end, it's what your gut tells you. Is it the right thing for me to do? But if you can inform that gut with as much logical information, numeric information, communicated to you in the right way, it can make that gut decision better. And we know, again, studies from people who are shared decision-making gurus, that when patients make decisions based on numbers and logic versus emotion, they have stronger confidence in their own decision than they do if they made it based on an emotional construct. So decisional certitude or decisional confidence is also part of quality of life.
Exactly.
If you're making decisions based on your healthcare in this, again, we've kind of lost the phrase heterogeneous in HCM, although every slide through the 1990s and 2000s had it.
Yep.
If you're unconfident in your decision, because in retrospect, gosh, I feel like I was reacting to the moment. Well, if you can say, I made the decision because I think a 7% risk for sudden cardiac death sounds super high and that scares me and I'm going to stop traveling unless I get this device, then you're suddenly confident in your decision and you're much more confident about your life in general. So it's a very complicated nuance. Not every person is the same. Let's not fall into our global political and cultural thing of being black and white. There's a billion shades of gray here, but if we can move things to where we are giving people the information to make decisions for themselves based on data, based on evidence, rather than emotion, I think it's a better pathway.
The numbers still confuse people.
Yeah.
And I try to liken it to, do you know what your, based on where you live, do you know what your risk of being in a car accident is every day? Do you know how risky it is to drive to the hospital to get your echo?
Yeah.
And, if you start balancing where there are risks in your life and where you're willing to accept those risks and what risks are too high.
Yep.
And we do that every day in our lives in so many ways. What we eat, what we do or do not do in exercise, all of these are risks.
Well, that's what has been framed as part of the art of consultation. So there are some patients that come into that discussion who are more numerically oriented. And so they get that very numeric information and they can move forward pretty rapidly. There are other patients who don't think as numeric as others. And then as the consultant, our job is to try to communicate with them what those numbers mean, translate it into something that's more tangible for them, or try to have that conversation in a way that at the end of it, you both feel like you were talking about the same thing and making decisions based on that same construct. And that is again, the art of the consultation versus recipe-driven, cookie-cutter, black and white medicine.
You and I have both dealt with a fair number of individuals who have tried to minimize the complexity of what it is to be on either side of the HCM coin, the clinician side or the patient side. It is confounding very often. The decisions that you have to present to the patient and the decisions we must make, they're not easy decisions and nobody has a definitive black, white, right or wrong answer.
Right.
It's what does the preponderance of evidence tell us and what are you willing to do?
Right.
And it's complicated. I have dropped links to the ESC risk score, the AHA risk score, and the kids risk score, which is different than the other two. The other two do not deal with children. This is evolving science.
Well, the current AHA one actually does incorporate the kids risk score into it if you get the right link from AHA. So once you enter the age, then it automatically populates it with the right math.
Okay, the one I have here is from 16 to 80.
Yeah, so there's a newer version that allows you to enter the age, and then it will give you both the HCM risk kids and the primacy score.
Oh, good. Thank you for that update. I did not know that. I will make sure my staff knows it as well. Okay, so we know how to determine, we know the conversation about risk and device to no device, but it's not just a device. We have a lot of options now.
Yep.
And we have new things coming with total leadless not too far away.
Yeah.
And now the EBICD, which has a lead that sits under the breastbone, but outside of the heart, down the center. We have the SICD, which has leads that are over the bone. So many options.
Yep.
What does a patient really need to know when it comes time to make the call? What device do I get?
Yeah, well, first of all, the patient needs to know that they deserve a thorough description of the pros and cons of each of those, and that their particular situation may make them ineligible for one or more, depending on the shape of the waveforms on their ECG. Some of the devices don't work for them based on whether or not they need pacemaker function. Some of the devices don't do that. So let's kind of review them, kind of go through the pathway. The kind of common, been around the longest version is something called the transvenous ICD, meaning through the vein. So this is devices you're very familiar with. They're like pacemakers. The computer and battery pack is implanted underneath the left collarbone. There's a wire that's inserted into the subclavian vein, which then goes down into the right side of the heart. The lead has a tip that screws into the tip of the heart. And so it's in direct contact with the heart. These are super effective. They can detect abnormal heart rhythms, and they can detect if it's coming from the top or bottom chambers, which is important for making sure therapies are delivered for the right thing. When they detect abnormal heart rhythms, they can do some things that the patient cannot feel to try to take control of the electrical signal, to override what's happening and gradually walk it back down in a painless way. And if that doesn't work, it can deliver shocks, which the patients will feel, but can reset the heart. Very effective, been around a long time. What are the downsides of this system? The fact that there are components in the bloodstream and in the heart. So if a patient with a transvenous pacemaker or transvenous ICD gets a bacterial infection in their blood for whatever reason, bad urinary tract infection, they were in an accident, got all kinds of skin lesions, scrapes, cellulitis, and they got bacteria in their bloodstream, it can infect.
But I went to the dentist 2 days before their wedding and got endocarditis.
That too. That infection can sit up on the pacemaker wire or lead, or it can infect the pocket itself. In either case, if you have bacteria in your bloodstream and you have a device in, the whole system has to be removed in order to heal you of that infection. It doesn't happen a lot, but when it happens, that's a prolonged hospital stay, a device extraction, which is far more complicated than a device implantation, and then another hand-wringing decision about when and if we should put a device back in. The other complication that lead wire going through the bloodstream can have is that it goes across one of the heart valves in the right side of the heart, the tricuspid valve. And if it puts too much tension on that valve, it prevents that valve from closing properly. And so people can get tricuspid valve regurgitation or a leaky tricuspid valve, which can cause lots of peripheral edema, swelling, fatigue, those types of things. And so we do a handful of times a year have to take patients to the operating room to get that lead secured in a spot where it's not going to impair the function of that valve.
So I've just asked somebody to run me in a box of hearts so we can, I'm going to give everybody a warning. I'm going to actually show you what leads look like inside of the heart in a little bit. I will warn you before they show up there. If you could put that up there and open the box for me, Stacey, I'd appreciate it. I don't often have an assistant in Tales from the Heart, but today I do. So I'm going to actually show some lead placement. So if you want to see, stick around a little bit. And if you can't stand those photos, you'll know when to tune out.
So those complications are what led to the development of the subcutaneous ICD, which is completely outside of the bloodstream and outside of the heart. So you're not having those infection problems. You're not having the tricuspid valve regurgitation problems. This device is the computer and battery are planted more kind of underneath the left armpit with a wire that tunnels underneath the skin and next to the breastbone, as Lisa said before. It can detect the abnormal heart rhythms. If it determines those are ventricular arrhythmias that are dangerous, it can deliver a shock. It can't do the painless anti-tachycardia pacing, but it can deliver a shock. It's a bigger device. For some people, the implantation is a little bit more uncomfortable because of this tunneling across the chest muscle, across the chest, but it avoids all that infection and tricuspid regurgitation aspect.
Okay, I'm going to show an actual anatomic heart. It belongs to Lori Ann Peachy. Thank you, Lori. She was at our annual meeting this weekend, and she's been public with her heart before. And I'm going to bring it up, and you're going to see that she had a biventricular, so she has 3 leads in here. But this is where the lead sits in the right ventricle. So this is going to be attached to the can, so the actual device that's going to sit up here. And these are where the actual leads sit inside of a heart. This is her left ventricle, kind of a sick one.
Can you point out her tricuspid valve on that, Lisa, so that where the lead is going through, just so you can see how easy it is for it to impair the function?
Yeah, it's kind of hard to see it up there, but you see here's where the lead comes in.
Mm-hmm.
And then up here is where the tricuspid valve would be.
Well, but actually, if you flip it around, it was on.
You can see it better on
Yeah,
the. Oh yeah, duh.
yeah,
Duh.
yeah. So you can see the tricuspid valve is kind of pointing diagonally down right there, and so you can see if there's too much tension on that wire, it's going to prevent one of those leaflets from swinging closed like it's supposed to. Yep.
Okay, and then we have Victoria has a very pretty picture of her lead. Boom, there it is in the ventricle.
Yep.
And then up through tricuspid, you can see a little bit angled up there.
Yep.
So they sit a little bit differently in everybody's heart. And thank you, Stacy, for being my magician's assistant today. Poof, the hearts are gone. No more hearts, people. So getting those leads in there. I mean, I had a number of leads in my old heart. They all got ripped out, so you can't see them anymore. But they're in there for a long time. My first set of leads went in 1992.
Yep.
And they came out in 2017, and they were just telling me my atrial lead was a little wonky at that point. The impedance rate wasn't working. But from 92 to 2017, that's a long life for a piece of equipment.
Yep.
How many things in your house last that long?
Exactly. Yeah.
Stacy's leads are from 2003.
All right. Yeah. So you can see then why the subcutaneous ICD was developed, but then it came with that fact that it couldn't do the anti-tachycardia pacing. It is the one that some people just aren't eligible to get, because if the QRS and T waves, which are the ECG waves, are too similar to one another, that device can double count them, and you're more likely to get inappropriate shocks from your device. And so some people just aren't eligible for it, which leads us to the development of the EV, or extravascular ICD. It's implanted in a similar spot underneath the left armpit, still tunnels across the chest, but then, as you said before, it dives underneath the breastbone and actually sits on top of the heart. So it is in contact with the heart, which means it's better at discriminating or differentiating which rhythms are dangerous and which ones aren't. And it can do the anti-tachycardia pacing, and it has no components in the bloodstream at all, and doesn't cross any valves. So we have been promoting this for many, particularly with our younger patients who are eligible for ICDs, who choose to get them, going to the EV ICD because of those benefits.
So we get anti-tachycardic pacing, we get pacing, period. Mm-hmm. We get defibrillation, but we don't have leads inside the heart. And you say it's making contact. Does it scar into the heart from the outside? I don't know this.
I think I'm sure eventually it adheres to the heart, and there's a layer of scar or endothelialization that occurs that adheres it to the heart. Yeah.
Okay. So we are going to be having a webinar coming up soon on the new technologies and devices, so that we can make sure everybody's staying up to date on all this. So stay tuned for that one. But in the global perspective of sudden cardiac arrest, and I had this conversation with somebody yesterday, and I'm going to say something that my family has been impacted by multiple cardiac arrests. Grandfather, uncle, sister, like we've dealt with it. Mm-hmm. But it's actually very rare. It's an incredibly rare event, even in HCM. It's not like HCM patients have their ICDs going off every single day. Right. They're still very rare events. But when you're told you're at higher risk, your spidey senses just shoot right in there and you're elevated. But it's actually uncommon. Yep. It's rare. So can you discuss how we balance a rare event, but a really scary rare event?
Yeah, I mean, it obviously just raises the stakes, which is why this whole risk assessment, risk stratification, and communication, which by definition means dialogue in this case, understanding what the patient's goals, wishes, and fears are, and helping them understand whether a device is the right thing for them, because it's not automatic. I mean, if the rate of sudden cardiac death was 50% in HCM, then it's easy. Everyone should just get one. Right. But when it's that small of a number, it makes it even more problematic, because it's too high for us to ignore, obviously, because we don't want patients to die unexpectedly if we can prevent it. But we can't give blanket statements about who should get it. And, when I think about it, and if any of my patients happen to be listening, they will recognize the way I've approached this with them. I often give examples of other patient groups and how they have approached this, and just to see if that helps the patient frame their own thoughts. So often when the patient at risk is the parent of a single-digit age kid or more, they're more likely to get a device because there's other things that are motivating them to want to stay alive, obviously. When we have patients, again, I live in the rural upper Midwest, and there's lots of people who do things like go into the boundary waters for a week or more at a time. They are more likely as a group to want to get out of the woods with a defibrillator than not have a defibrillator and never come out of the woods if something were to happen to them. I have a very unique patient who was a businessman who lived in a major US city, whose condominium where he lived and his office were in the same high-rise building, and they had automatic defibrillators on the wall. And he said, I spend 90% of my time in that building. I'm going to take my chances that someone's going to know how to use the AED if I go down. I have people based on whether their mother, brother, sister, friend had a pacemaker defibrillator, depending on whether that was a good or bad experience, obviously influences their choices. And yes. I have people that will very clearly say to me, Doc, I'm not looking for more years. I'm looking for quality years. And when my number comes up, I want to go quickly, and this device won't let me go quickly. So everyone brings their own thoughts, their own secret family recipe to this discussion. And we will use the numeric data. We will use the risk factors. We use the fact that certain risk factors mean it's recommended you get a defibrillator versus it's reasonable to get a defibrillator versus we're not sure, but we can justify it if the patient's super anxious. We use all those parts of the conversation to help patients try to make a decision. And in the end, often it comes down to, again, if you've heard that you have a risk factor, are eligible for an ICD, and you have X% risk, if knowing that is going to make you live a less fulfilling lifestyle because you're afraid of dying while doing it, then maybe a defibrillator is the right thing. Unless you think that having a device in your body is going to occupy your thoughts. And that does happen to people as too. People wonder, what's it doing today? Is it going to shock me today? How do I deal with this? So it is not an easy conversation. There is not a single discussion or even 10 different discussions. There is a different discussion with each patient on what it means for them.
It's a lot to process.
It is.
And I've always advocated that patients really take time to think about the decision. And as I referred to it, you need to make friends with this concept.
Yep.
If it's an invader, that's psychologically where you're going to see it forever.
Yep.
If you accept that this is an emergency room in your chest, 24 hours a day, 7 days a week, sleeping or awake, it's there for you.
Yep.
It's got your back. It's going to shock you potentially. And you make friends with the concept.
Yep.
It's a good relationship. I loved my defibrillator. When I left the hospital, okay, if you're a parent, you can understand this. And if you're a puppy parent, maybe you can even understand this. When you leave the hospital with a baby and you're like, are you serious? You're letting me go home with this thing? I might hurt it because I don't know what I'm doing. It's kind of the same idea when you're going home with a new heart. So I was going home with my transplanted heart without a defibrillator. And I thought that was a crazy thing to do, that I probably should have a defibrillator in this new heart because it's so special and I got to keep it safe. And they're like, you don't need one. It took me about 3 or 4 months to be comfortable without a defibrillator because I depended upon it so much. And any palpitation, I'm like, it's got me. Yep. But they let me go home without one. And so far, well, she did require a leadless pacemaker, which I thought was the stupidest concept I had ever heard in devices. Don't ever mock technology, people. You might need it someday. And that's what happened to me in my transplanted heart. So devices can be your friend, but if you don't need one, you don't want one. It's a risk as well. The leads are a problem. There's cost associated with it. There's maintenance associated with it. And the other thing I've been trying to do, Steve, on the podcast is tie in some public policy issues to the issues that we're talking about. And needing a defibrillator is kind of an important thing. And if you're at high risk and you need a defibrillator, you need a defibrillator. And if your only access to healthcare is through Medicaid or an ACA plan, right now you're probably feeling very anxious. And you're wondering, how am I going to get my device replaced? So I wish I had some magic answer for you. But my magic answer is call your elected officials and tell them what your needs are. Because we can only do so much from our point of view, getting your points across to the lawmakers who are determining what method of healthcare delivery system we're going to use in the United States. We need access. And defibrillators are not inexpensive. And young people at high risk of sudden cardiac arrest have a really high likelihood of also being on Medicaid or an ACA plan. We want to protect all lives. So please make your voice heard. There's some elections coming around. Vote for what's important to you. That's what I can say about that. Steve, anything from the Midwest on that topic?
I am going to stay away from that topic, Lisa.
I can imagine you might. But stay tuned, Minnesota. We might have a piece of legislation that we might be dropping come the beginning of the year. So stay tuned. We'll talk to you more about that later. Okay, Steve, any final thoughts on sudden cardiac arrest Awareness Month? If anybody has any questions, now would be your last chance to post them today. We had a great question on atrial fibrillation and myosin inhibitors. But want to wrap it?
Yeah, I think it's just summarizing some things that have been said, but the reality is that most people with HCM will die from something not related to HCM.
Yep.
So even though we're talking about this really important topic, as Lisa mentioned before, it happens in less than 1% of patients with hypertrophic cardiomyopathy each year. Every patient should talk about it with their provider, but most patients will not be directly impacted by this. So it is a nuanced discussion. It's not easy. Even for those of us that we exclusively take care of patients with HCM, it's still not an easy discussion with patients. So it's an ongoing, evolving risk assessment and discussion with our patients.
I love that we are the family communication tool for some of these HCM families, because we have very specific call outs from family members to pay attention to this particular episode. So Lorelei, I hope your family members are paying attention, and I hope they come and they get some education while they're making their decisions on their next devices. Anything else we need to close out? Take 2 seconds to talk about some PTSD that might be related to somebody who's experienced a shock. That it's real.
It's real. Psychological impact of having cardiovascular disease is real. It's been documented for a long time. It is well known that people that have heart attacks or have had bypass surgery way back 20, 30, 40 years ago, they were having major depression because they were faced with their own mortality. Well, you can only imagine that also applies to someone who would be dead were it not for an emergency medical responder or an implanted device. So it is a real thing that if you get shocked, it's going to have some psychological impact on patients, and includes a formal diagnosis of PTSD in some, particularly if they've had more than one shock.
The fear of the shock can sometimes be more impactful than the shock itself. So don't be afraid to get some help if you've had a shock, inappropriate, appropriate, whatever. We're here to listen. We are working on the creation of Hearts and Minds and Mental Health Network that will be able to address those particular issues more specifically, coming up hopefully by the end of 26. So we hear you, and we know that that's a really hard time, and we want to make sure that we have services that are there for you, and we are creating that. So final announcements. I've talked about this the last couple of podcasts. We did get approval on our patient registry to become an IRB approved patient registry. That means we can consent you all now to join the registry and take your lived experience and put some power behind that by being able to do some analysis over what are the unmet needs of the HCM community. What else can we do to support you? We're going to be holding some group classes where you can learn about the registry and receive a consent document so that you can consent into the registry at whatever level you want. That'll be explained in the seminars. And we're going to have a lot of classes opening up. We're going to try to do this like once a week where you can jump on and take a class and learn about the project and consent. We had about 20 people consent at the annual patient meeting already. So we have consented people in the data set. So we're off and running. We only have, about 8,000 more to go. So it's going to take a little while to get y'all in there, but the most effective way to do that is in groups. So you'll be invited privately to a group. We will be informing you that you will be in a group with other patients who are going to be there for the same reasons. So you don't have anonymity in the groups. If you would like a private intake or you would like a private consent session, we'll have that set up for you as well. So you can learn in a group, you can learn privately. You can even come to the office and consent in person if you wanted. So lots of opportunities and lots of events coming up. We will be out in Pittsburgh next month. We have our 26th calendar that's going to get nailed down, hopefully in the next 48 hours. And we're going to have some save the dates out there for around the country. Dr. Steve Ommen, thank you and your team at Mayo Clinic for all the great things you do for HCM patients every day. Thanks for joining us on Tales from the Heart.
Have a great weekend, everybody.
Thanks, Steve.
The Hypertrophic Cardiomyopathy Association would like to thank our sponsors, Cytokinetics, Bristol Myers Squibb, and Edgewise Therapeutics.